We are discussing in details at airway disorders. Yesterday, we had looked at bronchial asthma as an inflammatory process, reversible with a little bit of bronchial hyperreactivity, with mucus production. We looked at the PFTs, we looked at presenting complaints, examination, and we also had a detailed map of pathophysiology, and we looked at what is the management. So let's look at the other airway disorder today. This one is COPD, chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is a heterogeneous condition, means it has two conditions combined, emphysema and chronic bronchitis. It presents with increasing shortness of breath and sputum production. It primarily affects the airways. It is persistent and a progressive airflow obstruction. Mind you the words, persistent and progressive airflow obstruction. Big difference than asthma, because asthma was eosinophilic derived inflammation, but on proper treatment was reversible. COPD is a progressive disease. It occurs due to inflammation from a noxious stimuli. Inflammation from a noxious stimuli, not an antigen-antibody reaction. It is not reversible. It's progressive. It's an inflammatory process. So COPD, very different from asthma. Okay. I showed some form of this slide yesterday. Now we know the differences. Asthma is an antigen-antibody reaction, CD4 lymphocytes, then Th2 cells, eosinophils, reversible. Airflow limitation is reversible. Whereas in COPD, it's a noxious agent which you inhale, which causes the damage. The cells of important cells in mediating the problem are CD8 lymphocytes, macrophages, and neutrophils, not much of eosinophils. So right away, we should know that COPD is not treated much with inhaled steroids. Big difference. Asthma, we were very big giving inhaled steroids. In COPD, we would not be very aggressive in giving steroids because the inflammatory cells do not respond much to steroids here. And this is a progressive disease. Over a period of time, it will continue to deteriorate. As we treat these patients, you can prevent slight decline in the function, but it will continue to be progressive over a period of time. It is not completely reversible, unlike bronchial asthma. A few other differences between asthma and COPD. Now, asthma we knew had two peaks in children, adults. COPD, you should not diagnose less than 50 years of age. It is a disease of the elderly. Asthma patients may have history of atopic dermatitis, skin lesions. COPD has none of that. Asthma patients have symptoms which vary from morning till evening. And COPD symptoms continue to work as patient exert throughout the day. So symptoms in asthma are variable. Symptoms in COPD are progressive. Airflow is reversible in asthma. Airflow is not reversible in asthma. Cell of inflammation in asthma is eosinophil. Cell of inflammation COPD is neutrophils. On spirometry, there is a positive bronchodilator response, more than 12% and 200 cc improvement. On spirometry, it is not present. The FE1, FEC is low in both of them, but it recovers in asthma. It does not recover in COPD. There may be a family history of asthma, which is very strongly related to the presence of asthma in children. COPD, not that much. Chest X-ray generally in asthma is normal. In COPD, in late stages, may show the changes. Okay, let's look at COPD cause. The cause of COPD in this country is exposure to smoke, cigarette smoking. Cigarette smoking ultimately affects the alveoli in a different way. So when the person smokes, it leads to recruitment of the smoke that you inhale It reaches the lungs, it recruits neutrophils, then there's some certain enzymes are released by the neutrophils which cause damage to the lung. So if you take a cut section of the lung in normal patients, healthy patients, this is a small bronchiole and these are the alveoli around it. That's a normal looking patient, lungs. In patients with chronic obstructive pulmonary disease, not only is the bronchus filled up with mucus with lymphoid hyperplasia, as you can see, there's very little lumen left. Also, the walls of the alveoli around the bronchus are broken, so it's more easy for the bronchus to collapse. These are two processes. Inflammation of the small bronchioles is one, and damage to the alveolar wall is the second. Emphysema is the damage to the alveolar wall, damage to the airways leading to chronic bronchitis is two. So that is why chronic obstructive pulmonary disease, it can be chronic bronchitis predominant when this part is more predominant, or it can be pure emphysema when this damage is more predominant. So that is why when we look at the Venn diagram yesterday, there are patients with asthma, but COPD patients are two types, chronic bronchitis, some have emphysema, and there's a little bit of overlap between all of them. Make no mistake, the most common cause of COPD in this country and rather even the worldwide is cigarette smoke. Now, patients smoke for nicotine addiction, but the smoke has so many other particles which go inside the alveoli, start an inflammation and damage to the airways as well as the alveoli. So there are two big phenotypes of COPD. Yesterday, we learned what is a phenotype. Phenotype is presentation of the clinical syndrome of the disease, various presentation. In asthma, it was asthma with early onset asthma, late onset asthma, early onset asthma with eosinophilia, then it was late onset asthma, non-eosinophilic and eosinophilic, that kind of thing. COPD is two different phenotypes, chronic bronchitis and emphysema. Patients with chronic bronchitis are a little bit more healthy, means they are younger. Emphysema patients, older. Shortness of breath is mild, but it starts early in chronic bronchitis, late in emphysema. Cough is present in both of these. Right heart failure, symptoms of right heart failure are more common in chronic bronchitis. It is rare in emphysema. Airway resistance is much more increased in chronic bronchitis. Recoil of the airways is normal in bronchitis, much more low in emphysema because the walls are broken, so the airways remains closed early. Patients with chronic bronchitis may have cyanosis, they may have blue bloaters. So this, as the picture shows here, they may have a little bit of cyanosis, where emphysema patients are pink puffers, means pink very much because they have erythrocytosis. Increased erythrocytosis is present in patients with emphysema. Emphysema patients are cachectic, as you can see, lot of loss of muscle mass. Bronchitis patients generally have their preserved skeletal muscle mass. So two different phenotypes. Now, most of the patients that you will see in your clinical medicine, both patients will have both emphysema and chronic bronchitis features, both of them at the same time. Rarely pure emphysema and pure chronic bronchitis patients, generally less than 5% times. That's why, since most patients with COPD have both these features going on at the same time, we call it as chronic obstructive pulmonary disease. To put it in terms of the pathology, where is this damage? Remember, trachea, bronchus, it keeps dividing till the time the 16th bifurcation when you reach something called as terminal bronchiole. Terminal bronchiole is the last, smallest bronchiole which has cartilage. It leads to something called as respiratory bronchiole. Respiratory bronchiole does not have cartilage. Respiratory bronchiole leads to something called as alveolar duct. Alveolar duct. An alveolar duct leads to alveoli. So the damage can be in the respiratory bronchioles, alveolar duct, or alveoli, and then causes different kinds of emphysema. So there are 3 different types of emphysema seen on CAT scan. Most of the time, we just call it as chronic obstructive pulmonary disease, but radiologists sometimes, when we do a CAT scan on these patients, try to make this connotation, what kind of emphysema. In some patients, when only the alveolar ducts are damaged, or respiratory bronchiole is still a little bit preserved, only the alveolar ducts are damaged, it's called as paraseptal emphysema. When the respiratory bronchiole is damaged more, it is called as centrilobular or centriacinar emphysema. When everything is involved, both respiratory bronchiole, alveolar duct, and alveoli are involved, it's called as panlobular or panacinar emphysema. So there are 3 different kinds of emphysema that can be seen on a CAT scan or on biopsy. We never do biopsy in COPD patients. We don't need to. We can diagnose it very easily. So just to let you know, there are 3 different types of COPD, at least on the basis of anatomy. We don't make that distinction because treatment remains the same for all 3 types. That is why generally we don't go to doing CAT scans on COPD patients to see this. It's not necessary. The diagnosis is based on spirometry. A few words about the lung function. I talked about this a little bit yesterday as well. Same slide in a different way. When patients are born, this is when the child is born. As time passes during puberty, the improvement in the lung function. This is how the lungs improve. We agreed yesterday by 18, 19, 20, the lungs are fully developed. Some patients have a very nice development of the lungs. They are always, as time passes, at the age of 25, 30, I said you start losing lung functions, etc., etc. But even at the age of 90, the loss of lung function is not much. You remain healthy. So some patients have a supranormal or a normal response. These patients never develop any lung problem. These are not COPD patients. These are healthy patients. But if a child is born at term and has no problem, as they start growing up, if they don't develop their lungs properly, so at the age of 18, 19, there is a little bit slightly decreased lung development. As time passes, they may actually start losing lung function. These patients who don't achieve optimum lung function, optimum TLC, at the age of, by the age of puberty to 30 years of age, they start to decline over a period of time. They may lose more lung function by the time they are 80. But think of a patient, if he's born regularly, but they start smoking, they will have a faster decline in their lung function, That's the patient, even if they were born regularly, but there is a fast decline in the lung function, that's the patient develops COPD. So cigarette smoking is a risk factor for COPD, period. And then second group of patients are those who do not develop their lungs properly. These are patients, children who are born premature, or you get repeated bacterial infection during childhood, so the lungs don't develop, but instead of coming up till here, 100%, at the age of 25, they only develop to 75% of what is expected of them. These patients also will develop some kind of obstructive lung disease. So 2 main biological reasons to develop COPD, either abnormal lung development, or secondly, accelerated decline with aging. Accelerated decline with aging. This is smoking related accelerated decline. Second one, if the child is born before 40 weeks of gestation and the lungs don't develop properly, they can lose lung function and have obstructive lung disease. So there are 2 types of patients who can develop of COPD. Most commonly that you will be seeing in your life are those who have healthy, but over a period of time they smoked, so there is accelerated decline in the lung function. So what are the other risk factors for COPD? The biggest risk factor for COPD is smoking cessation. The second one is a enzyme called as alpha-1 antitrypsin. Its deficiency leads to emphysema. Smoking, whether it is primarily smoking, secondhand smoke exposure, both can lead to damage to the lungs and COPD. Second group of patients are those who have an enzyme deficiency called as alpha-1 antitrypsin deficiency. Just to let you know, if you diagnose 100 patients with COPD, there will be only 1% of patients will have COPD on the basis of alpha-1 antitrypsin level deficiency. That's smoking related, alpha-1 antitrypsin, early life events like premature birth, low birth weight, and leading on to the development of obstructive lung disease. Cigarette smoking we talked about. It's just not cigarette smoking. It can be vaping, it can be cannabis, anything, inhaling products which are injurious to the lung. There is some thought process when the children get repeated infections, major pneumonias multiple times in the child, their lungs will not develop properly. They may be at risk as well. And lastly, I talked about some patients, they may have asthma, but if it is not treated properly over a period of time, inflammation in the airways make it fixed obstruction, so they develop COPD as well. The most important factor in treating COPD is smoking cessation. Put together in another way, the primary prevention of COPD is smoking cessation. Let's look at these graphs. Here are a group of patients. This is age 25, 50, 75. These are their FEV1, 100% of what is predicted of them, 75%, 50, 25%. So generally, patients have their 100% lung developed by 25 years of age. We learned that yesterday. After that, at the age of 30, you start losing lung function. And if you remember, and if you're awake yesterday, I did say that in patients with normal lung function after age of 30, the loss of lung function is about 25 cc per year. 25 cc per year. So just lose a little bit of lung function. So TLC at the age of 30 is 5 liters. At the age of 31 would be 4,975. Age of 32 will be 4,950, and so on and so forth. Slight decline in lung function. This is normal decline in lung function. These patients never develop COPD. Look at a patient who has developed 100% of their lungs at the age of 25. At 30, and then they started smoking. If you smoke, and I want you to remember this number, if you smoke, you would lose 75 cc per year. 25 cc per year, healthy people after age of 30 lose their lung function. Smokers lose 75 cc per year after the age of 30. So here, this person then, if he starts to smoke, he's losing lung function faster, faster, faster. A time comes when he's left with only 25% of his lung volume, and they are very short of breath. The good thing is, anytime this person quits smoking, next year he loses only 25 cc. See? So the curve improves. This is the rationale for smoking cessation. If you quit smoking, you will lose only 25 cc next year. But if you continue to smoke, you will lose 75 cc per year. So there is accelerated decline in the lung function in patients with COPD who are actively smoking. It is never too late to quit smoking, because once you quit, your lung function actually gets better and you lose less lung function next year. So primary prevention of COPD is smoking cessation. Okay, and smoking is the biggest cause of COPD. The next one, let's talk about alpha-1 antitrypsin. Alpha-1 antitrypsin is an enzyme which is produced in the liver, not lung. It is produced in the liver. It is produced in the liver from hepatocytes. It's released in the portal hepatic veins. There are 3 hepatic veins which drain into the IVC. IVC drain into the right atrium to right ventricle, and right ventricle pulmonary artery and reaches the lungs. That's where this enzyme then seeps out of the pulmonary artery and reaches the alveoli. A deficiency of alpha-1 antitrypsin will result in emphysema. Very important. Patients with alpha-1 antitrypsin deficiency will develop emphysema in the lower lobes. Remember that when I was in the class, we had talked about diseases which come to us by blood flow are more common in the lower lobes. COPD is an upper lobe disease because it's smoking related. But COPD from alpha-1 antitrypsin is a lower lobe emphysema. That's one big difference. Secondly, since it's a genetic defect and patients not producing alpha-1 antitrypsin, this emphysema starts showing up at 20 years of age. That is the only time you will diagnose emphysema less than 50 years of age. I keep saying this. I don't know why students still don't get it. They keep diagnosing COPD in 25, 30 years of regular people. So emphysema in lower lobes, you should think of alpha-1 antitrypsin deficiency. Let's look at it a little bit more. What does alpha-1 antitrypsin do? Alpha-1 antitrypsin is produced in the liver. It is released in hepatic veins. Hepatic veins take alpha-1 antitrypsin to the IVC, IVC to right atrium, right ventricle, and pulmonary artery. From pulmonary artery into the smaller venules, and then capillaries, and then it diffuses into the alveoli. That is where alpha-1 antitrypsin reaches. Okay, so alpha-1 antitrypsin is present in the alveolar wall. Okay. Let's talk about healthy people. There's a reason why you and I, even if we inhale particulate air, bacteria, viruses, when we go on LIRRs, bus, malls, shopping mall, people are breathing all over each other. The breath is not sterile. It has bacteria and viral in it. Why is it we don't develop pneumonia every day? It's because of this enzyme alpha-1 antitrypsin. This enzyme is present in the alveolar wall. So whenever there's a bacteria which goes into our lungs, it's in the alveoli. Your neutrophils, which are present in the alveolar lining fluid, release an enzyme called as neutrophil elastase. Neutrophil elastase. Neutrophil elastase goes and binds the bacteria and kills it. It lyses the wall. It's a proteolytic enzyme. The extra neutrophil elastase that is present is neutralized by alpha-1 antitrypsin. So there is always more alpha-1 antitrypsin than the elastase, neutrophil elastase present in the alveolar wall, so that the alpha-1 antitrypsin keeps on neutralizing the free-floating neutrophil elastase. Now think of a patient who has alpha-1 antitrypsin deficiency. If they have an alpha-1 antitrypsin deficiency, their alveolar fluid has less alpha-1 antitrypsin. So this time when the bacteria goes into their lungs, the neutrophils release the enzyme elastase, neutrophil elastase, it goes and kills the bacteria. The leftover neutrophil elastase can go and damage the alveolar wall and break it. That's what causes the emphysema. So alpha-1 antitrypsin deficiency patients can develop emphysema. Since these patients are deficient in alpha-1 antitrypsin from day one, they start showing emphysema at a very earlier age, around 30 years of age, 20 years of age. So alpha-1 antitrypsin deficiency related emphysema is seen in younger population, less than 20 years of age, and it is lower lobe predominant, whereas the garden variety COPD is an upper lobe disease. Okay. How do patients with COPD present? In my first lecture, we had discussed. They present with shortness of breath, they present with cough, they present with sputum. Sputum may be a little bit rust colored, and at times these patients may have expiratory wheezing because it's an airway problem. So if you just look at the symptoms, and this is the severity of the disease from patients going on from left to right are becoming more severe. Initially, patients have cough and sputum. When the disease becomes a little bit more pronounced, they start having exertional dyspnea. Late stages, they will have resting dyspnea. Cough, sputum, exertional dyspnea, resting dyspnea. If you do spirometry in these patients for a long period of time, this is normal. Then it has mild obstruction, FE1 by FEC less than 0.7 or a lower limit of normal, then moderate, and then severe obstruction. So spirometry, even mild obstruction is seen in patients who have very minimal symptoms. So spirometry helps us diagnose this condition much earlier before the patient actually starts feeling shortness of breath. What about arterial blood gas? Arterial blood gas is normal till a very late stage of time. By the time patient has moderate to severe emphysema, their PaO2 is less than 60, room air saturation is less than 90. Can chest X-ray help? As I told you, chest X-ray in the early mild disease and even early moderate disease is normal. So chest X-ray abnormalities, if you start seeing in a patient, you suspect COPD with hyperinflation, they generally have very advanced disease. Okay. How do we diagnose COPD? Again, subjective findings, objective finding, and spirometry. Three things. Subjectives. Patient must have cough, sputum, shortness of breath, history of wheezing. Patient must have some risk factor, history of smoking, primary smoking, secondhand smoke exposure, indoor biomass pollution, which is a cause of COPD outside when the people cook inside their house with wooden stove and things like that. They inhale the products, they develop COPD as well. So history of cough, sputum, shortness of breath, these are the patient subjective complaints. And there's a history of either smoking, primary smoking, secondhand smoking, or history of exposure to biomass, indoor biomass fuel kind of things. Those things can cause COPD. Diagnosis requires spirometry. It is post bronchodilators have spirometry, and FEV1 by FEC should be less than 0.70 or less than the lower limit of normal. FEV1 by FEC less than 0.70 or FEV1 FEC less than lower limit of normal. That is diagnostic. Few summary slides. I've shown this kind of graph before. Patients on a healthy on this side, on this time patient with COPD. We are seeing a volume, time curve. Patient takes a deep breath in and exhaled out till 6 seconds. This to this is the FVC or forced vital capacity. What he did in first minute is the FEV1. This is FEV1, this is this thing. Normally FEV1, FEC is 0.80 or higher. In patient with COPD, they take a deep breath in, cannot breathe out too much. The FEC is decreased, the FEV1 is much more decreased, the ratio is less than 0.70. We can divide this condition into mild, moderate, and severe, and very severe, 4 grades of the severity of the disease based on spirometry. If a patient has FEV1, FEC less than 0.70, then you look at the FEV1 per se. If FEV1 is still preserved more than 80%, it is mild disease. If it is 50 to 80, moderate disease. 30 to 50, severe disease. Very severe, less than 30% of FEV1, predicted FEV1, it is very severe disease. In the clinic or in the outpatient setting, we look at subjective findings, we look at objective examination findings, and we look at spirometry and ancillary data. So what do we took from the sputum patient subjective findings? They have shortness of breath, they have cough, they may give history of expiratory wheezing. Once that's the case, we want to look at spirometry to confirm obstruction by looking at FE1 FEC ratio. We also look at patients' risk of exacerbation. How many times patient has had exacerbation of his COPD, and we'll define COPD exacerbation a little later on. FEV1, lower the FEV1, higher the mortality. FEV1 is a predictor of mortality. Lower the FEV1, higher the mortality in our patients. So we look at patients' symptoms, we look at spirometry, and we look at patients' risk of exacerbation and in the how many times he has had COPD exacerbation in the last 1 year. So 3 things: patient's symptoms, patient's spirometry, patient's exacerbation. How many exacerbations he has had in last 1 year. We can quantify the symptoms where a patient tells you, I'm very short of breath or mild short of breath or short of breath only on running. This is way to look at it. You can be more objective, give them a scale, something called as Modified Medical Research Council, MMRC's dyspnea scale. Please do not try to remember it. I give it to the patient to fill it out. That in the outpatient setting, we sometimes do in the inpatient setting. This is not something that you would need to remember. Just to know, we can quantify patients' dyspnea on a scale. One of the commonly used scale is called as MMRC dyspnea scale. If you have shortness of breath, even at rest, and very little work, it's grade 4. Less than that, grade 3, grade 2, grade 1, or if you're not short of breath, grade 0. Higher the grade, more short of breath you are. We can all be a little bit more fancy and give them a questionnaire to look at shortness of breath in various scenarios. And this is something called as combined assessment tool, COPD combined assessment tool, CAT score as we call it. It has multiple scenarios and it is a Likert scale 0 to 5. Higher the score, more severe the disease. These 2 things only pulmonologists do. Students don't have to remember. Just to know, you need to ask patient how short of breath they are. More shortness of breath, more severe the disease. So based on this, we divide our patient into 3 groups. Remember, asthma, mild progressive, moderate progressive, severe progressive. This in COPD, we divide this group into 3 groups, A, E, and B, or A, B, and E. Let's take you through this. This is how we approach. Patient has shortness of breath, history of smoking. We did a spirometry, ratio is less than 0.70. You have COPD. You have to have a history of smoking or risk factors, cough, shortness of breath, expiratory wheezing, and spirometry shows FE1 FEC less than 0.70 or lower limit of normal, you have COPD. We go ahead and on the basis of spirometry, we try to divide the severity of the disease. I just talked about it. Very mild disease or no disease or gold stage 1 as we call it, FE1 is still more than 80% predicted. Gold means global obstructive lung disease. AB assessment tool is what I'm talking about. Gold is global obstructive lung disease. If I have FEV1 between 70 and 79, 50 and 79, it is gold 2. If my FEV1 is 30 to 49, this is gold 3. And FEV1 less than 30 is gold 4 stage. So one more time. History of shortness of breath, history of smoking, physical exam, expiratory wheezing. We did a spirometry, shows the ratio less than 0.70. COPD is confirmed. Then we look at the severity of COPD on the basis of FEV1. Then we look at how many times patient has had exacerbation. Exacerbation means one of the 3 things. More shortness of breath than the baseline, more sputum production, more sputum purulence. Any of these three present, you have a COPD exacerbation. So we ask the patient how many times you've had the symptoms before. If it is 0 to 1 exacerbation in last 1 year, or more than 1, or more than 2 exacerbations last 1 year. We divide the group into 3 groups, A, B, and E. Please wake up now. A, B, and E. Group A are those who have less exacerbation, 0 to 1 exacerbations, and have very little dyspnea. Combined assessment 2 less than 10, MMRC scale 0 to 1. Minimal symptoms, no or low exacerbation. Group A is minimum symptoms, and very low exacerbation in last 1 year. Obviously, these people are much healthy. Group B are those patients who have still low exacerbation, but higher symptoms, more shortness of breath, more cough, more MMRC scale is more than 2, combined assessment tool is more than 10. The third group of patients, group E. It does not matter how much, where the symptoms are. If they have had more than 2 exacerbations in the last 1 year, you automatically become group E. So A, B, and E. This is very similar to what I presented in asthma yesterday. A is mild persistent, B is moderate persistent, E is severe persistent disease. Okay. We try to do this because the treatment depends on where the patient belongs to. A, B, and E may be approached a little differently in terms of treatment. I do want to bring it to your attention that exacerbation of COPD, increased shortness of breath, COPD production, sputum production or sputum purulence, has very serious connotation in terms of COPD exacerbation. Exacerbation means more airway inflammation. It is associated with higher mortality. It is associated with poor quality of life and faster decline in lung functions. All of these are present in patients with more than 2 exacerbations. That's why this group is called as group E, A, B, and E. And those who have more than 2 exacerbations have more inflammation, more death, more poor quality, and more decline in the lung functions. I also want to point out that patients with COPD have some other comorbidities which come in the exam all the time. Patients with COPD are more prone to pneumothorax. We learned that in my first lecture. They are more prone to infections. They are prone to primary lung cancer, which is upper lobe predominant. They're more prone to osteoporosis. Polycythemia means increased hematocrit. Hypoxemia. Pulmonary hypertension means right heart failure. Coronary artery disease. And ultimately respiratory failure. All these things are much more common in COPD. All I said for asthma was that if it continues to go unrelenting, it will turn into a COPD kind of fixed disease, and these patients then will develop respiratory failure. But COPD, I want you to think of as a systemic disorder. Depression, osteoporosis, lung cancer, polycythemia, pulmonary hypertension, coronary artery disease, all present in COPD patients at a much higher incidence. What are the goals of treatment? Okay, I'm not going to go into detail of diagnosis. We diagnose it on spirometry. We also test the severity on spirometry. We know this. Now, goals of treatment. Let's look at what the treatment is all about for COPD patients. We want to relieve their symptoms. We want to improve their exercise tolerance, ultimately improving health outcomes. And we also want to prevent decline in lung functions. So the treatment is based on 2 concepts. Reduce the symptoms. You give bronchodilators and do other things to reduce the risk of progression. This is smoking cessation comes in here. Medications come here. Just like asthma, as I talked about, there's a circle. You diagnose these patients, you start the treatment. At the time of treatment, we decide which gold stage they are, gold 1, 2, 3, 4 in terms of FEV1. We also decide whether it is A, B, and E in terms of their symptoms and exacerbations. You will still also check in all your patients with COPD, you will check blood eosinophil level and alpha-1 antitrypsin level. Alpha-1 antitrypsin level should be checked in all COPD patients to make sure that rare alpha-1 antitrypsin deficiency patients, because their treatment is different. And also, eosinophil count should be checked. This is a big change in last 2-3 years. We were very big on Th2 cells and eosinophils in asthma. We know that. But today we know there is some type of COPD patient who have an overlap with asthma kind of features. Those patients will continue to have high eosinophil levels. So we want to look at this. Initial management is smoking cessation, physical therapy, and medications to help with bronchodilation. Patient comes back to you every month or 2 months. You look at their improvements, change the pharmacotherapy, and this circle continues as we go along. So let's look at the treatment of COPD. As I said, the treatment is based on a paradigm of reducing symptoms and reducing risk. Let us reduce the risk. By reducing the risk means making sure the patient does not smoke. I just want you to know the reason why people smoke cigarette or BD or hookah or vaping or marijuana, and be my guest, whatever you want to do. The reason why people do it, that once they take this product, nicotine goes into your lungs. From lungs, it gets absorbed into the blood vessels. From blood vessel, it goes, circulates, and reaches the brain. It crosses the blood-brain barrier and crosses the brain. And in the brain, you stimulate an area called as ventral tegmentum area, VTA. VTA, if it is stimulated, sends signal to an area called as nucleus accumbens. If you haven't highlighted it on your slides, please do it, because it is crucial for people to know that nucleus accumbens is your reward center. The reason why a person keeps going back to the same activity again and again is because every time they involved in that activity, whether it is eating, even exercise, smoking, cocaine, marijuana, alcohol, all these things lead to increased dopamine levels in nucleus accumbens. And increased dopamine levels in nucleus accumbens means that patient is satisfied, there's a feeling of satiety and having achieved something. How funny is that? So our addiction center is nucleus accumbens that gets stimulated with smoking. So can we prevent this? Because once it is done, but once slowly the levels of dopamine in the nucleus accumbens starts to go down, patient goes back to the same activity again. So the reason why some people are smoking only 5 cigarettes and others 25, because everybody's delay in the dopamine in the nucleus accumbens is different. Some are fast, some are slow. Those who are slow, they require less cigarettes per day. Those who are fast require more cigarettes per day. So if there's more level of dopamine nucleus accumbens, there is no need to smoke. So maybe we can do something to increase the dopamine level in nucleus accumbens. This can be done by providing patients nicotine gum, nicotine spray, nicotine water, etc., etc. So nicotine replacement therapy, whether it is patch or it is gum or lozenges or water or inhaler, will increase the dopamine levels in nucleus accumbens and patients won't smoke. So that is one way of causing smoking cessation. The other way is to give a drug called as varenicline. I highlighted it, varenicline. Don't show up on the exam without knowing varenicline. Varenicline is the drug of choice for smoking cessation. It has results in more improvement, more smoking cessation. So varenicline is the drug of choice for smoking cessation. Just to let you know, an antidepressant called as bupropion can also be used, but its effect is much less as compared to varenicline. Its effect is much less than the varenicline. And also bupropion, it's a kind of drugs cannot be used in patients who have anorexia nervosa and things like that. Okay. So first you have primary prevention, which will be smoking cessation with counseling the patient using vareniclines or nicotine replacement therapy or even bupropion. Let's learn a little bit more pathophysiology of COPD so that we can tailor-made our treatments appropriately. The airways, our lungs are supplied by the vagus nerve. Vagus nerve carries parasympathetic fibers. Parasympathetic fibers at their nerve endings released acetylcholine. So in patients with COPD or in normal patients, when there's acetylcholine is secreted, there is slight bronchoconstriction. But in COPD patients, their vagal tone is very high. So more acetylcholine is being secreted. So they start with a very bronchospastic airway as compared to the healthy people. Yes, you can see. One way to cause bronchodilation would be to give anticholinergic agent, and to be very specific, anti-muscarinic agent, and that will cause bronchodilation. So from now onward, the drug of choice for COPD is anticholinergic agent. Drug of choice for asthma was inhaled steroids. Drug of choice for COPD is an anticholinergic agent, and to be very specific, anti-muscarinic agent. Now, cholinergic agent pathways have two receptors, nicotinic receptors and muscarinic receptors. In lungs, these are muscarinic receptors, so you need to give anti-muscarinic agents. That is the drug of choice for COPD. Please remember it forever, and it will come in the exam. What are the other drugs we can use to cause bronchodilation in our patients? We can use beta agonists, both short-acting and long-acting. We can use some inhaled steroids. It may not be as effective. There can be some other drugs, two other drugs. One of them is called as roflumilast, which is a phosphodiesterase 4 enzyme inhibitor, which also causes bronchodilation. And lastly, there's a new drug for the last 2 years. It's called as ensifentrine. So cholinergic agents, long-acting beta agonist agents, roflumilast, ensifentrine, also called as Otuvair, but remember it is a ensifentrine. This is a phosphodiesterase 3/4 inhibitor. Roflumilast is a phosphodiesterase 4 inhibitor. That's the slight difference between the two. Ensifentrine also leads to bronchodilation. It also has anti-inflammatory properties and also helps with mucociliary clearance. So ensifentrine is also a drug of choice for COPD. But the best drug for us is an anticholinergic agent or specific anti-muscarinic agent. Many of these things are combined. You combine with LAMA and LAMA. LAMA means long-acting muscarinic agent with a long-acting beta agonist. You can combine LAMA with inhaled steroids. Ensifentrine is available as a single inhaler, and roflumilast is a tablet. But many of these combinations are available. Don't go crazy over remembering this. So types of delivery system. I have shown you this before as well. You can have a dry powder inhaler. You can have a meter dose inhaler. We talked about it yesterday in asthma. There's something called a slow mist inhaler. These are the inhalers. But when patient is very sick, you will use a nebulizer. This is nebulizer when patients in the hospital. When patients at home, they can be on any of these 3 types of drug delivery devices. For anti-muscarinic agents or beta agonists or inhaled steroids, we use these kind of drug delivery devices, meter dose inhaler, slow mist inhaler, or dry powder inhaler. We talked about it a little bit in one slide in asthma as well. These three are in outpatient basis. Nebulizer is to be used in patients when they are in the hospital. So let's look at the treatment. Once you have decided patient has obstructive lung disease, by doing spirometry, you look at the severity of the FEV1 by looking at whether it is 80%, 50 to 80, 30 to 50, or less than 30. Then patient's symptoms, you divide them into A, B, and E. A are no, very little dyspnea and no exacerbation or one exacerbation. B is more dyspnea, but less exacerbations. And CE are those patients who have, whatever their symptoms are, they have more than 2 exacerbations in last 1 year. So what is the treatment? Group A can get just a PRN, as needed inhaler. It can be short-acting muscarinic agent, SAMA, or a short-acting beta agonist. In patients with COPD, you would prefer SAMA, because remember, patients with COPD are elderly. They are at risk for arrhythmias, atrial fibrillation, things like that. So short-acting beta agonist, if you take too much of it, it's going to cause tachycardia. So group A patient gets either a short-acting muscarinic agent or a short-acting beta agonist. Group B are those who will get a combination of LAMA and LABA. LAMA is long-acting muscarinic agent. LABA is long-acting beta agonist. You see, in A and B, we do not use inhaled steroids. We do not use inhaled steroid. In asthma, everybody was getting inhaled steroids and formoterol. I hope everybody remembers. In COPD, the drug of choice, initially drug of choice is LAMA, and then you add a LABA to it. If a patient who has very minimal symptoms, otherwise healthy, you can get by just giving as and when needed short-acting muscarinic agent or short-acting beta agonist. Here you start with LAMA, but quickly go to LAMA-LABA. In group E, you will still only use LAMA and LABA, but if patient has high eosinophil count, you can add an inhaled steroid. You see, now you understand. Patients with COPD, we do not use too much inhaled steroids. In patients with asthma, we want to start with inhaled steroids and keep going up and adding other medicines. Very different philosophy here. So A is a short-acting bronchodilator, any kind. Group B, LAMA or LAMA-LABA. Most of your patients will be on LAMA-LABA combination. Group E, there's no C anymore. Group E, LAMA-LABA ICS or LAMA-LABA, depending upon if patient has high eosinophil count or not. If patient has an exacerbation, if patient has dyspnea, you start with LAMA-LABA combination. Most of patients are doing LAMA-LABA combination. If they're still having more shortness of breath, sometimes you can use ensifentrine as well. I want to let you know ensifentrine is a new drug only for last 2 years. As we are learning more about it, we will use it more extensively. But for shortness of breath alone, if no exacerbation, for shortness of breath alone, use LAMA, then LAMA-LABA, then LAMA-LABA, ensifentrine. LAMA, LAMA-LABA, LAMA-LABA, ensifentrine. But if my patient has an exacerbation, more sputum production, sputum purulence, and more shortness of breath, then I would shift to 2 types. I would either give them LAMA-LABA ICS, and if they continues to have high eosinophil count, I will add a biologic called as Dupixent. Remember, we talked about Dupixent. I mentioned it in asthma. It's a biologic agent that you can use in severe resistant asthma patients. If that's not the case, you can use, if patients has LAMA-LABA ICS and their eosinophil counts are low, you can either add roflumilast or Zithromax Monday, Wednesday, Friday as an anti-inflammatory agent for 1 year. I do want to caution you all that you all think of azithromycin or Zithromax as an antibiotic, but no, it also has anti-inflammatory properties. So sometimes in patients with COPD who are on triple therapy, LAMA, LABA, ICS, and they're still not feeling better, we would then add either roflumilast or we will give them azithromycin, 1 tablet 3 times a day, three times a week for 1 year. If patients on a LAMA, LABA, ICS and has high eosinophil count, that patient will now be treated with adding a biologic therapy. The biologic therapy approved for COPD is Dupixent or Duplimab. Please don't show up on the exam without knowing Duplimab and its role in COPD. Everybody knows its role in asthma. Everybody knows its role in nasal polyps. Everybody knows its role in atopic dermatitis. But slowly, now we see there's a group of patients with COPD, despite being on LAMA, LABA, ICS, they continue to have high eosinophil count, and those patients benefit from Duplimab as biologic therapy as well. Much more detail than you ever wanted to know about the management of COPD. For the bronchodilation, as I said, for regular as needed, group A, it will be SAMA or SABA. For group B, you can start with LAMA, but most patients will be on LAMA-LABA combination. Patients group E would be on LAMA-LABA or LAMA-LABA ICS combination therapy. Why don't we use inhaled steroids very aggressively in COPD? There is a thought that patients with COPD are elderly. Since they are elderly, their clearance of oral mucosa is poor. So, and their hand-to-mouth coordinations are not very good. So their medicines stay in the mouth even if they don't gargle. When it stays in the mouth, it can lead to development of pneumonia. That is true that severe COPD patients may have a higher risk of pneumonia with inhaled steroids. This is new information. I want you to know this. That's why we try not to use inhaled steroids in COPD. We use those patients with COPD who have more than 2 exacerbations in last 1 year, those who have high blood eosinophil count, or known history of asthma and COPD, we will use inhaled steroids in addition to LAMA-LABA. I always ask side effects. We talked about side effects of the steroids yesterday. Let's look at the side effects of some of the medicines which are used for COPD as well. Beta agonists, short-acting beta agonists can cause tremors, palpitations, hypokalemia, and arrhythmia. That's why short-acting beta agonists is less preferred as compared to short-acting muscarinic agents as relieving agents in patients with COPD. In asthma, it is SABA. In COPD, it is SAMA as the relieving agent of choice. Anticholinergic drugs are the drugs of choice for patients with COPD to start with, and they can cause dry mouth, urinary retention, glaucoma, and sometimes arrhythmias. You should know it. Inhaled steroids can cause dysphonia. Sometimes they sit on the larynx and cause edema there, so patient can lose their voice. It causes oral thrush, as I explained to. There is a slight risk of increased risk of pneumonia in COPD patients with inhaled steroids. We should know this. Roflumilast, the one thing I want you to know, it causes weight loss. It causes weight loss. Now you look at the emphysema patients, they already have very low muscle mass. So we don't want these patients to have continue have diarrhea and things like that. So that does it. Azithromycin, not only it can build up the resistance of the bacteria in the community, long-term use in elderly population can cause hearing loss. It can also cause arrhythmia. So these are the side effects of these medicines we must know. Don't show up on the exam without knowing them. What else can we do for our COPD patients? If they have alpha-1 antitrypsin deficiency, then these patients get infusions in their arm with pooled plasma from healthy donors. We take patients, donate blood. From the blood, the alpha-1 antitrypsin is extracted out, and that is replaced in patients with COPD who have alpha-1 antitrypsin deficiency. It is known to show progression or decline the progression of lung disease. What else do we do for our patients? We do smoking cessation. I talked about the nucleus accumbens as the addiction center. Please know it cold. And secondly, the drug of choice for smoking cessation is varenicline. We also do for our patients pulmonary rehabilitation. I did not say anything like that in asthma. Pulmonary rehabilitation, patients come to the pulmonary rehab area in the PFT lab. They are taught breathing exercises and things like that and diaphragmatic function. All patients with COPD should get yearly flu vaccination. After 65, one-time pneumococcal vaccination. You should get pertussis vaccination because pertussis can cause severe lung disease. This is generally part of the DPT. Nowadays, we also recommending COVID vaccinations and shingles vaccinations. These are the vaccinations which are recommended for patients with COPD. Just like bronchial asthma, the past thing is, first you assess the inhaler technique, start LAMA, then LAMA-LABA, inhale steroids, then roflumilast or enphestrine and azithromycin. And lastly, if still not helping and high eosinophil count, Dupixent or dupilumab, as we call it. Patient should see you every 6 months. You readjust the thing, make sure patient's taking it properly, and keep managing their dyspnea and exacerbations. What is pulmonary rehabilitation? Pulmonary rehabilitation can be done as an inpatient. It can be done as an outpatient. Basically, patients are taught to breathing exercises and diaphragmatic exercises. It helps to alleviate the feeling of dyspnea. Pulmonary rehab patients do better in terms of their exercise tolerance. This is also true for COPD. Once they start losing lung function, remember it's a progressive disease. At some point, they will require supplemental oxygen therapy. I did not mention none of this in asthma lecture. COPD patients, once their lung functions become very poor, they will require supplemental oxygen. Now, what is the level at which you will give oxygen to the patient? Here it is, remember it cold. If the room air ABG shows PaO2 of less than 55 or room air saturation of less than 88%, patient should get supplemental oxygen to be used at least 18 hours of the day, 365. At least 18 hours of the day and every day of the year. PaO2 less than 55 or a saturation less than 88%. We know supplemental oxygen in COPD patient improves hypoxia, it improves cognitive function, it improves exercise performance, it improves sleep quality and other activities of daily living. Patients with COPD, remember my first lecture, ultimately PaO2 goes down, then the CO2 also starts to go up. If their PaCO2 is more than 53, then they are candidates for non-invasive ventilation. It can be a BiPAP or a CPAP, etc. These patients use this device not only in the nighttime, but also during the daytime as well. Most of the time, we recommend that they do it in the night time. So non-invasive ventilation is also to be recommended in COPD patients whose room air CO2 is more than 53, whose room air CO2 is more than 53 millimeters of mercury. Something more that is being done more and more is called as endobronchial valve placement or endobronchial lung reduction surgery. What is that? In patients with COPD, we go in and implant these valves in the smaller bronchioles. These are one-way valve, means the air can come out from the area so that it collapses. It causes atelectasis. So that the bad area of the lung, you would in the bronchus, you would place this so that it collapses, so that the other healthy area of the lung expand. So endobronchial valve replacement is being done for emphysema. There are specific indications. Time will not permit me to go into these. I also want to emphasize Severe COPD patient, those who are CO2s are higher and doing poorly and everything has been done, are candidates for lung transplant. I did not mention lung transplant in any of my previous lectures, at least for asthma. There is no need. We can treat it and reverse most of the disease if you use their medicines effectively. Vaccinations we talked about. What about the exacerbations? Let's look at the exacerbations in COPD a little bit more closely. What is COPD exacerbations? Patients will have more sputum production or sputum purulence or increasing shortness of breath. If 3 of 3 are present, severe exacerbation. 2 of the 3 are present, moderate exacerbation. 1 of the 3 is present, mild exacerbations. Mild to moderate exacerbations are treated at home. Severe exacerbations require patient comes to the hospital. Another way, it's an event characterized by dyspnea, cough, sputum that worsens within 14 days and may be accompanied by tachypnea, tachycardia, often a severe increased local inflammation. The best predictor for future exacerbation is the constant decline. More the decline in lung function in FEV1, more at risk for COPD exacerbations. Mild COPD exacerbation is treated with increasing the frequency of short-acting bronchodilators. Moderate is treated with short-acting bronchodilators plus antibiotics and oral steroids at home. Severe exacerbations require hospitalization, may require IV and oral exacerbation and antibiotics. Okay. The most common virus associated with COPD exacerbation is rhinovirus. The bacterial infections may also cause COPD exacerbation, and some patients may require antibiotics. Let's look at the treatment. This is a more detailed diagram which talks about COPD exacerbations. Once it is, how do we see that? The dyspnea is higher, the respiratory rate is higher, saturation goes down, mild, moderate, and severe exacerbations. We can give specific criteria. I'm not asking that. Always COPD exacerbations, you'll do a chest X-ray to make sure patient is not in heart failure, pneumonia, and things like that. Patients with COPD get exacerbation from bacterial infections, viral infections, fungal infections. Only 70% of the time we can actually characterize in the sputum what is causing the exacerbations. Whenever there's a bacterial, viral, fungal, pollution, stress, it causes more inflammation. Inflammation causes more obstruction in the airways, so more wheezing, more hypoxemia, more tachypnea, more trapping, hypercapnia, and dyspnea. This is a cycle that goes on in patients with COPD exacerbations. So how do we treat it? I'm going to make a very similar slide in asthma as well, because sometimes I see students confuse it. For exacerbations, we will give them more frequent. Just like bronchial asthma, every 10-minute short-acting beta agonist to relieve dyspnea. And if patient is in hospital, you will give it through a nebulizer. You will give it through a nebulizer. We will also give patients supplementary oxygen. This is very important in COPD patients because they are generally more hypoxic. Asthmatic patients are not hypoxic till very late in this game. COPD patients start becoming hypoxic much earlier in life. Just like asthma, we will give oral steroids here. SABA or SAMA with nebulizer, supplemental oxygen, oral steroids. And if there is suspicion of any infection, bacterial infection, we'll give antibiotics. If patient CO2 is elevated, we'll give non-invasive ventilation. While all this is going on, you use this opportunity to remind the patient to quit smoking. Once at the time of discharge, now at the time of discharge, you will change to LAMA, LABA, or possibly ICS at the time of discharge. Make sure patient is immunized That's an opportunity to make sure the patient has pneumonia vaccine, flu vaccine, COVID vaccine, shingle vaccine, things like that. And after the discharge, something I didn't mention for asthma was that patient must go through pulmonary rehab within 4 weeks to teach them breathing exercises, function of the diaphragm, peripheral muscles, things like that. Patient should be seen within a week of discharge. And those patients, some of these patients may need roflumilast or amphotericin or zithromax added to their regimen. LAMA-LABA ICS and then roflumilast, amphotericin, or zithromax added to the regimen to prevent further exacerbation rate. I just want to remind you the oral steroids are not continued forever. They are only continued for 5 to 7 days at the most, and then we stop it. And patient continues with LAMA-LABA ICS, and then you see it and then decide whether you want to continue it or you want to add roflumilast, azithromycin, or ensifentrine for your patients. These are the things which decrease exacerbations. LABA alone, LAMA alone, but the best exacerbation decline occurs from LABA and LAMA. That is why in stage B, we prefer LAMA and LABA combination, though I said single inhaler may be possible as well. Things which decrease exacerbation, because exacerbation really points towards mortality. So the best drug for LAMA-LABA is for preventing exacerbations, LAMA-LABA, and those who have high eosinophils count, LAMA-LABA ICS. Roflumilast also decreases exacerbation rates. Vaccination, macrolides decrease exacerbation rates. Smoking cessation decreases vaccination rates. Lung volume reduction surgery decreases exacerbation rates. And sometimes during winter season, wearing a mask, following social contact, etc., minimizing it also decreases exacerbation rates. Just to remind you, we give antibiotics during exacerbations if we suspect patient has a bacterial infection. And in my previous lectures, I told you the 3 bacteria which commonly cause infection in the lung are H. influenzae, Moraxella catarrhalis, and strep pneumoniae. That is true for the bacteria which cause COPD exacerbation as well. Please don't show up to the exam without knowing it. But we also know viruses can cause COPD exacerbation as well. While patients having exacerbation, we have no time for sputum cultures and things like that. So we give antibiotics if we suspect any infections. That is the name of the game. SABA or SAMA as a nebulizer, oxygen, oral steroids, and antibiotics, and non-invasive ventilation is the start treatment of COPD exacerbation. It is much more involved than bronchial asthma. You do smoking cessation. At the time of discharge, you will send the patient on LAMA-LABA ICS and then decide in the office whether you want to add roflumilast, azithromycin, or ensifentrine. Make sure patient has immunization up to date, influenza and pneumococcus and COVID and shingles. Make sure patient learns how to take the medicines, otherwise keep them on nebulizer. Make sure you do pulmonary rehab for these patients. Make sure patient remains on oxygen till the time they see the doctor. Prednisone is continued for 5 days and then it is stopped. And patient continues to get monitored by the physician in the outpatient setting. This, in short, we have looked at the management of COPD, and I hope now compared and contrast asthma and COPD pictures are rather clear to you. They look common per se. Both are airway disorders. Both are associated with airflow obstruction. Both can result from environment interaction, antigen antibody in asthma, noxious stimuli, smoking cessation, biomass gas exposure in third world countries causing COPD. But alpha-1 antitrypsin here and eosinophils here, neutrophils here, and things like that, I hope is clear to everyone. any question on COPD at this point of time? It's a very, very nice message. No, sir. We don't want to ask any questions whatsoever. When people don't ask questions, I think either everyone has understood everything or people have understood nothing. I want to take pride in my teaching, and I believe that everybody has understood everything. Tomorrow's lecture, it starts at 2 o'clock, 2 to 5 we will go. We will start with bronchiectasis, and yes, it's on the Zoom. So she will send me the link, and she'll send you the link as well. And if there are no other further questions, I'll see you people at tomorrow. But by the way, before everyone signs off, I want to know, are there any questions? Are there any things in the lectures that you're not understanding? We have a little bit of 5-10 minutes. You can ask me at this point of time, if anybody wants to ask.
Professor Talwar, I think you're on the schedule for 2:30 tomorrow.
Oh, is that 2:30? Then we go to 5:30. Is that what it is?
Yes. Yes.
So 2:30 to 5:30 we will go, and then we will tackle bronchiectasis and another lecture and things like that and go from there. Okay. By now, the airway obstructions is easier. So bronchiectasis should be an easier lecture because I wanted to take time to compare COPD and asthma. It's also very common. It's also asked very commonly in the exam. And if this is clear, bronchiectasis is a piece of cake and we can go from there. Okay.
Thank you. Have a great night.
Have a great night, people. Thank you very much. Bye.